It is just a huge, huge honor for me today to be podcast interviewing Dr. Jean Ching Wu, DDS. If she was in China, she would be introduced as Dr. Wu Jinqing. She's a prosthodontist at Sheets, Paquette, and Wu, and I've been trying to get her on the show since the day we started 4 years ago, and finally my dream came true. She's on the Executive Council for Pacific Coast Society for Prosthodontics and a past president for the Academy of Microscope Enhanced Dentistry. She is also a member of the American Dental Association, the California Dental Association, and the Orange County Dental Society. She was a board member of the Orange County Dental Society in 2011 and senior delegate in 2012. She is a partner in Sheets, Paquette, and Wu dental practice and on the faculty with Newport Coast Oral Facial Institute, a nonprofit international teaching and research center. She is also actively involved with several research projects on dental implants and materials and published articles in several dental journals. Experienced prosthodontist with a demonstrated history of working in the dental practice industry. She's skilled in endo, research, everything, sleep apnea. She's an incredible entrepreneur, and my gosh, she's joining us from a hotel because your Beverly Hills, a fire, the fires made you evacuate?
Yes, my residence is in Irvine, Orange County, California. My office is in Newport Beach, so we're probably about 6 miles from the fire because it was getting quite smoky this morning and there was a mandatory evacuation anyway. So my kids luckily were at home doing online schooling because of this COVID situation. So we took our dog, my mom, and we're here in a hotel, in the Hyatt Hotel.
Wow, that is crazy. So what do you make of all these fires? Is it just a part of being in California? I know when I grew up, we live in Arizona.
Yeah.
So we're always like, wow, we don't get hurricanes, we don't get fires, we don't get tornadoes. We're kind of a just it's kind of boring out here. But is it just a part of life in California that?
Well, I guess it's been dry. So with the drought, we're by the canyon, so there's a lot of brush. It started as a brush fire this morning, and then we've got Santa Ana winds. I heard it was 50 to 70 miles, which is, I don't know, a hurricane level wind. So when I woke up this morning, a lot of trees and, the backyard furniture was toppled over. And then we started to see the sky looking a little cloudy, but it was actually smoke. So when I turned on the TV, I could hear that there was some fires behind us. And then with the wind, it just turned from 50 acres to, I think, 6,000 or something like that in a very short time span. So it got a little scary. And then we got the Amber Alert saying there's a mandatory evacuation. That's when we packed up and left.
Wow. Well, my gosh. So what was worse news? The fire or having to come on my show?
I thought as long as I've got Wi-Fi, I have an ability to connect with you. So I didn't cancel because most hotels obviously have free Wi-Fi. So I hope I don't lose connection, but it seems like it's pretty strong. So no, I was looking forward to this, Howard. I think because your podcast has such a wide reach, especially to young dentists, I think as now in my 5th decade, I feel like an elder now, even though I used to be the junior member of the Sheets Paquette Wu practice. Actually, I still am. I'm the youngest of the 3 partners. I still feel it's important to obviously contribute. In fact, the first year after I graduated from the University of Melbourne in Australia, I was invited to come back and teach. So I, volunteered for half a day a week and went straight back into teaching. So I think we have a lot to offer, whether it's clinical experience, which obviously we've grown to have more of as we get older, but also wisdom and business experience, which they really don't teach you in dental school. So I think it really is important to share our experience because as a younger dentist, I always treasured those times when older dentists and professors and the, more experienced dentists would take the time to give us, their advice or guidance. And I think that goes a long way. It's just kind of a full circle.
And there's that human mentor guidance that's so real. But I'm 58. I just can't help but notice that, like all the Americans who are born in America and never left America. I mean, when they talk about economics, macroeconomic, anything, you can just tell that they're not worldly, or they don't get it. And it seems like whenever I find really, really sharp business people, dentists, whatever, they've either been international business people traveling the world, or they were born in different countries. You were born in China, lived in Australia, lived in California. And let me make an example of this. I noticed that in the 6 dental schools in California, if you were born and raised in the United States, you will come out of U of P, say $400,000 in debt, and then you will say that San Fran has too many dentists because there's this many dentists, the ratio. But it's all dentists from like Monday through Thursday, 8 to 5. And then you'll see someone who was born and raised in Vietnam, and they'll come out of dental school. The American will, after $400,000 in debt, will go buy a house and buy a car and then rent a dental office. I mean, they own the place they sleep and they rent the place they work. My God, if you were born in Nigeria, anywhere in Africa, Asia, South America, they'll go buy a dental office. They'll live in that dental office. They won't even get a house or a car, and they'll be open as long as they can answer their cell phone. And you come back, in 5 years out of school, they've got their whole student loan debt paid off, and they've got $200,000 in cash. Now, the American, you catch up with that guy 30 years later. They gone from 25 to 55, and he just upgraded to a bigger house on a 30-year mortgage. He's driving a Range Rover, and it's on a 5-year lease. I mean, I just think when you tell me you're a dentist in America that you weren't born here, I mean, you're just scale more worldly and full of wisdom. And since your name in China, Wu Jin Chen, Jin is crystal and Chin is clear, do you see that crystal clear like I do?
Well, I think I always knew that I had the best of all cultures. I was raised quite strictly I was actually born in Taipei, Taiwan, but nevertheless, the work ethic is very strong. So you were always, just from example, my parents ran a restaurant, so I lived above the restaurant. And so after school, I was obliged to help, work in the restaurant until after dinner was when I could go upstairs and do my homework. But as soon as I got home, you had chores and you were obliged to help with the family business. So I think from an early age, I knew the value of hard work and how that will pay off. And my parents operated the restaurant 7 days a week, dinner 7 days a week, lunch 5 days a week. We closed on Good Friday and Christmas Day. We never really went on vacations. I'm not saying that is a good balanced lifestyle. I don't think it was. I think they worked really, really hard. But I think in order to get ahead, they had to do that because, my mom had no college degree, but my dad was a diplomat with the Chinese government. So he was bilingual and taught himself how to speak English actually by reading the dictionary. And so that's why he was sent from Taiwan to Australia. And he saw an opportunity to be a chef and have his own business. So he left politics and opened up the restaurant because he knew that if he was his own boss, he could keep all the money instead of working for somebody. So I think that instilled in me that in order to get ahead, you have to work hard, try and be your own boss, invest your money, save your money, and make the money grow. So they invested in real estate. And I realized that there are other ways, obviously, to invest, but it was always that you don't spend all your money, that you try and keep enough money to make it grow and spend wisely within your means. And so, I was a waitress during high school and all the way through dental school in order to earn some pocket money. And my parents obviously helped me, as most Chinese families do, to help you with your school, paying your school and my dental school. But I paid for myself for my American degree because once I came from Australia to America, I had to go back to dental school. I met my husband at the University of Pittsburgh when I did a fellowship in maxillofacial prosthodontics. And after we got engaged, it was quite a sacrifice to move from Melbourne, Australia to Memphis, Tennessee. He's with FedEx. And so I realized after teaching at the university for a few months and volunteering that I couldn't not do any clinical dentistry and just be a faculty member. With my Australian degree, I was not allowed to treat patients. I could only teach in the clinic and not put my hands in patients' mouths, but I could tell them what to do. And so that was obviously not acceptable. So I went back and did a DDS degree at the University of Tennessee after I had already obtained a master's in prosthodontics and a 5-year dental degree in Australia. But I realized that not being a clinical dentist and just being a faculty member was not enough for me. So I knew I didn't feel confident in just being faculty without having clinical daily experience. So it was quite a sacrifice to do the dental school in 2 years instead of 3. I finished in 2. And after that, then that's when I came to California from Memphis, Tennessee. And that's when I met Charlene Sheets and Jacine Paquette through an endodontist. So just in your intro, you said that I can do endo. I actually don't do endo. I'm just a prosthodontist. But I met them through a very good friend, Gary Carr, who's an endodontist in San Diego.
Yes, I know Gary. He's the only dentist on earth who kicked me out of his class because me and Mike Totola were not endodontists. It was for endodontists only. So we had to sneak in. And so thank you, Gary.
Well, he was very kind to me because I spent a day with him and he said, you've got to go and meet Charlene Sheets and Jacine Paquette. And so I drove up. I was living in San Diego at the time, and that kind of changed my trajectory because I was ready to buy into a practice in San Diego.
Well, I don't like to ever talk about religion, sex, politics, or violence, but I have to bring it up when it's fair. When I got to school, out of school in 87, there was about an 85 probably, Jewish woman who escaped Nazi Germany before Hitler took over. And when she got to Arizona, she was a dentist in Germany. I mean, this isn't, a dentist in, some crazy country. This is Germany where they make Mercedes-Benz. She comes to the land where they make Chryslers. And they said, you can't be a dentist. And she was married. She just left everything she had in Germany. And but the lawyer said, but, the loophole is you can own a dental office. So it forced her to own a dental office, but can't do it. And so by being that way, when I got here, she had a north, south, east, west. She had a driver, like a limo, literally a limo driver, and she just drive around. She just had the high life. But I was sitting there thinking, I just don't think it's what America is based on. I mean, she came here from Germany. I understand that the Arizona State Board can say, well, Howard went to dental school in Kansas City, Missouri, where Dr. Jean Chen Wu went to Australia. We only license Howard because you have to go to an American dental school. But they don't say, well, Jean is not licensed or approved by Arizona. They say, not only are you not licensed, you can't practice. And if you do, we'll hire the mob, the police, to go arrest you, kidnap you, put you in a cage, and deport you. And they did it with the person that I bought my McMansion from, some poor lady that owned her own business, made millions, just the epitome of a human, and she got brain cancer, and an American pharmaceutical company had a drug, but it was in FDA trials, and she said, well, why are you doing it on rats and monkeys? I'm volunteering. No, you're not allowed. And so she had to sell the house to me, move to Scandinavia, where she could get the American drug, and it's like, okay, the FDA has not approved this drug. I understand that, but I'm dying from the disease. And they said I'll be dead in 6 months, and you're spending years on rats and monkeys and mice. Can I just try it on me? And the government says no. So now that you've been here and been practicing for decades, do you think that the board should just, or the FDA should approve a drug or not approve a drug, or license you or not license you, but not use measured violence to keep you from selling your drug or doing dentistry on someone who wants you to do it on them?
Yeah, I think I understand. Now you can be licensed or by credentials. So at the time, they did not accept my credentials. But now, if you've been a dentist, I believe, for 5 years in your home country, you can pass a series of examinations and be, accredited or be eligible to sit for the state boards. So I, at the time, felt that it would be maybe a weakness if I just got my license in California, because I could have done a series of examinations to obtain my license in California, but it would have taken almost just as long. So I decided to get a DDS in case we went to another state, because if I just obtained licensure in California and we decided to move to another state, I would have had to overcome that state's hurdle or that regional boards. So I decided if I was to stay in America, I better get an American degree and not be at a disadvantage to, if we wanted to move or if I wanted to make a change. So I took that route, but I could have done part 1 and part 2 of the state requirements and then be eligible to sit the state boards at that time. But I figured it was more powerful to get the DDS degree and be recognized in America. So I think you need to protect the public from and maintain a standard of care for dentists wherever you're from. I mean, I felt that Australia was part of the Commonwealth, equivalent to Canada, England, Singapore, many first world countries. So it's not like I was from a third world country. And so I think we should have been able to show via our transcripts and maybe by equivalency accreditation of my school, which was a main school in the city of Melbourne, which is a 4 million people population in Australia. We should have been able to compare the credentials and accreditation of the school. But maybe now I think it's a little easier for foreign dentists. But at the time, I just didn't want to be held at a disadvantage, to be able to transport or move if I wanted to. So I chose that route. But in order to answer your question, I think the safety, the public, whether it's drugs, whether it's clinical dentistry, there should be some measures and certain criteria to keep the public safe. And then some sort of common sense and sensibility has to come into play as well. If you have a dental school in a first, developed country like Australia, which is equivalent to Canada and England, although some could argue that the dentistry in those states or those countries are socialized and maybe inferior, but I would beg to differ. I think it's, first of all, safe. And those countries use kind of the same materials, the same textbooks, the same philosophies of safety and clinical standards. We should be able to compare them and be able to still keep the patient public safe.
I grew up in Kansas and went to dental school in Nebraska. Creighton in Nebraska for undergrad, and dental school Missouri. And I gave my first lecture August 4th, 1990 in New York City, only because this little country boy wanted to see New York City. And I still can remember to this day, like it was just looking out the window, then all of a sudden realizing that black canyon over there was buildings, just blew my mind. And I think the single greatest thing I got out of lecturing was to go meet other dentists in other countries. And I am so impressed by Asia. I mean, Taiwan, Japan, Korea. I got to speak at the World Dental Conference in China. And again, I don't want to go into politics and all that stuff, but man, Asia is just so exceptional. Like Taiwan has the same, Fareed Zakari was talking about this on Sunday. Taiwan and New York State have the same population, and Taiwan had 7 deaths from coronavirus, and New York State had 34,000. You're born in Taiwan, you're in California. What is the difference? Why? Why did 34,000 more people die just in New York State than in Taiwan? And Taiwan was right across from Wuhan.
I think they realized the transmission, the mode of transmission early, and the public followed the guidelines of, wearing a mask and social distancing, and they were willing to be controlled, I guess, by the government in terms of their movements, and businesses with screening and temperature and tracking and testing. So I think, obviously, in America, we're very protective of our rights and freedom of speech, and so I think that comes at a disadvantage of just people feeling unable to accept that the government has certain implied restrictions that keep us all safe. And so, it doesn't need to encroach upon your freedom of speech, but it's just common, society protection and empathy for your fellow man to try and do what we can to keep each other safe. So in Asia, there was no disagreement about having to wear a mask and being tracked and tested and temperature taken at every business, and, maintaining a certain restriction on people's movements and travel, because they knew it was for the common good. So in those countries who are accepting of that, the population was safe. So in America, it's harder to police. We've got a bigger population. People don't want to be tracked. People want their freedom. People want to be able to express themselves. And so I think that is a more difficult task for the government to control us. We don't want to be controlled.
But then they go out and get married. I mean, come on. Talk about hypocritical. But do you agree that they wear the mask differently in China? Because I remember the first time I went there, I thought for a couple of days that they were wearing it for health reasons for them, for pollution, whatever. And then my friend educated me saying, no, she's probably worried that maybe she has a cold and she doesn't want to spread it to everyone else.
Yeah. I think a lot of people in Asia do wear it for pollution and air quality, but I think they are also aware of whether it was SARS or other flus, or swine flu, other contagious disease, or even TB, and that it could be communicable with, saliva. And so in order to maintain personal hygiene, that is probably a good idea to protect yourself and others.
Yeah, so you're in Newport Beach. So for our international lecturers, where's Newport Beach for the international people? Is that just a suburb of LA?
If you can imagine, south of LA, north of San Diego, along the coast. A lot of people have heard of probably Laguna Beach because there's some TV shows, reality shows based in Laguna Beach. So we're right along the coast of the Pacific Highway. It's a very affluent part of Orange County, which is south of LA. It's probably about 40 minutes without traffic from LAX airport, an international airport. It's also maybe an hour north of San Diego, which is another very beautiful part of the coast along California. And then maybe another hour to the Mexico border. So if you can imagine, 2 hours from the Mexico border, 1 hour south of LA.
Okay, now if I got in my car at the Mexico, California, Tijuana, San Diego border and drove all the way nonstop down that big interstate to the California-Oregon border, how long of a drive would that be?
California-Oregon border. I don't know. I know from here to San Francisco, it's about 8 to 12 hours. Depending on what part of Northern California is. So I don't know. I've never.
Yeah, I mean, it's just a monster state.
It
is so big. Yeah, I mean, just crazy big. So another question I gotta focus on is when you came to the United States, or when you became a dentist in your lifetime, first in Australia,
yes,
and then in the United States, did you feel like it was a man's profession? Did you feel like being a woman was a minority? To talk about those days compared to 2020.
Yes. I graduated in 1990 in Melbourne, Australia. My class was about 50-50 female-male ratio. It had just begun to be about 50-50. I did feel when I graduated, that the practicing dentists were still predominantly male, that most female dentists were working part-time because of family. At the age that we graduate, we're usually married and childbearing age, and many women, and my friends included, would probably suspend their practice to go and have a family. And some came back part-time, and some actually never came back, unfortunately, because of various reasons, whether it was childcare or whether it was because of interest. They felt that their priority was their family and they could go back to practice later. I always felt that I could do both. And when I first graduated in 1990, I was not married and did not obviously have any children. So I threw myself 100% into my practice and was very involved with, the curriculum council at the school, with the ADA in my local branch, with the Prosthodontic Society. I just knew that in order to learn and to grow my business and my network, I had to be out. If I was just in my practice, nobody would hear of my name. So I luckily had some very strong mentors, people who were president of the Prosthodontic Society, people involved with the ADA, who nurtured and encouraged me because I was never afraid to speak. I think a lot of people who are shy, who don't like public speaking, or who don't feel comfortable standing in, or even in a group of people and to have a voice, may not be as actively involved, but I was never shy. I always, I guess I had a very strong father figure. When my father knew that I wanted to be a dentist, he said, just whatever you do, whether you're a dentist, whether you're anything, whatever you do, just be the best and be special. Don't be average. So I never wanted to be average. I always wanted to stand out and do something to make myself be special, whether it's in what I do, what I could contribute, whatever it was. I knew that I wanted to be above average. So when I was involved after dental school, I just found it interesting, as well as a good networking practice builder, to go back and just participate, whatever it was that I did. So I was out nearly every night, whether it's going to a meeting, going to a continuing education meeting, going to a study club. I just knew if I sat at home and watched TV, I would not get ahead. And so doors would open. So the more you get yourself out there, the more people you meet, the more opportunities fall in your lap. And if you say yes enough times, people, you have a reputation of being a contributor. So people would then ask me to participate and nominate me and encourage me to join their groups. And so moving myself up from, a secretary to a vice president to president of the Prosthodontic Society at a young age before I left Australia was all through just participating and being available and just saying yes and doing the best that you could when you did say yes.
And where along the way did Prosthodontics come in your mind? I mean, there's now 12 specialties. Yeah. Where did that come from?
I was always very artistic growing up. I love art and sculpture. So when I first graduated from dental school, I did life drawing, I did sculpture, I did ceramics. I was always visual and very tactile. So I felt that I didn't like endo. Sorry, endodontists out there, because I couldn't create beauty and form and function. I knew it was very important for obviously disease and pain control. And I critically, appreciated how important that profession was. I didn't particularly like scaling and root planing. I liked oral surgery, but I felt that I could do more with my hands in creating a change in terms of somebody's function and presentation and aesthetics with prosthodontics. So that always interested me, whether it's carving a simple amalgam or doing a wax up or setting some dentures. That excited me more than other things. Orthodontics is interesting in moving teeth, but I like to change shape and utilize that for also functionality. So prosthodontics always spoke to me. So I did a general practice residency my first year out, where I had a taste of oral surgery, trauma, perio, endo, and I that's kind of 1 year out where I did a little bit of everything, cemented my interest in prosthodontics. And then that's when I went back and did a 2-year master's in prosthodontics, and then a further 1 year in maxillofacial prosthetics.
And right now we're in the middle of a pandemic. I'm sure you got the memo on that. A lot of kids are sitting there thinking, maybe it's better to just stay in school and specialize. And unlike you, when you and I got out of school, there was only 8. They've added a whole slew. Now we're up 12. So now there's, and I'm going to put these in most demand as far as for enterprise, DSOs, all that. Oral surgery, endodontics, perio, pediatric, ortho, pros, dental anesthesiology, oral facial pain, oral med, oral path, oral radiology, then last but not least, dental public health. First of all, I want to back up a question. There was a lot of controversy with these new specialties, oral facial pain, oral medicine. Did you think that was a good thing, or as being a specialist, did you think it was diluting the water? How did you weigh in on those new specialties?
I think those new specialties, if it's complex and requires further education and more training, I think it is worthwhile. I don't know that it dilutes our profession. I think it only elevates the degree of sophistication and education and research in that arena, because dentistry is only getting more complex. I don't think it's easier to be a master of your craft. So if we have more highly educated, more specialty trained dentists, I think that only helps the profession in elevating the standard. I think what's key and important is that we are not too narrow in our vision. So even though you're a specialist, I think you should be obliged to at least practice 1 year out of dental school so that you know at least what all the other specialties do. Because if you go straight into your profession or your specialty outside of dental school, you have no idea what the practical real world dental experience is. And so if you're treatment planning or discussing a case with other specialists, it's difficult to do that if you've never experienced just general practice.
When someone tells me like you that you're a prosthodontist, is it, when someone says I'm a prosthodontist, is it mostly fixed prosto? I mean, is removable just kind of going the way of or would you say what % of your world is fixed versus removable?
I would say probably 90% is fixed, but it would be a shame if we lost the ability to be able to make a removable partial denture or full denture, because if you're doing all on 4 or all on 6 or, all on whatever, you need to be able to set the teeth in the right place. People don't come in with a perfect dentition and need all their teeth out and have it and transfer or transition to an implant supported prosthesis. If you don't know how to set a denture, if you don't know how to identify the occlusal plane and where to set your tooth fronts, tooth centrals, you're not going to be able to make any implant supported or even be able to digitally design a denture if you don't know those parameters. So you need to have some sort of ability to even make a provisional appliance. Not everybody can have a fixed provisional transitional appliance. Sometimes you need a removable appliance. So if you don't have any training in that or ability to service your patients with a removable appliance, I don't think you can adequately treatment plan or be able to, set the occlusal design for their fixed prosthesis. So I think it would be a shame if dental schools don't continue to teach, how to do removable prosthodontics, because that is an essential part of transitioning to a fixed prosthodontic solution.
Well, you're not going to like my answer to what you just said. The reason I got into implants in 1990 is because when I went to seat my upper denture,
Yes.
I couldn't let go of it because I didn't know if it was just going to free fall or have suction, and I was so scared. I finally got an implant because I figured the only way I could make an upper denture was to nail it down with a bunch of titanium. By the way, Kyle just sent me, it's a 12-hour and 30-minute drive on an interstate from Mexico to Oregon. My God, that's a huge state. But here's my theory. I think the people that get A's in math and physics and chemistry and biology, they didn't. They're not the. They're not extroverts. They're not people person. They when they're alone, they get renourished, and when they're out with people, they get drained. And on Dental Town, since 1999, it seems like the number 2 things that stress out people, or dentists, are patients and their staff. I mean, I think dentists are the happiest when they're in the lab, the door's closed, no one's in there, and it's just them and their Bunsen burner, or in the library. I mean, so when I tell them, you were talking about how important it is finding mentors, but I know my homies, and she's just too shy. But where I think your mentors can give you the most is not in helping you, you broke off the root tip there, let me help you get it out. It's in diagnosing and treatment planning. And my gosh, you're young and you want to network with a very distinguished prosthodontist, but if you called her up and said, can I go over some x-rays and a study model, whatever, that might be an icebreaker. And that's why I see the concern, again, not to go into politics, but like take global warming. I mean, the first thing they wanted to do, of course the mob, the first thing they want to do is shake you down for more money and do this carbon tax and all this stuff. It's like, whoa, wouldn't the first thing you do is get all the scientists in one area and figure out exactly what's going on and get a diagnosis and treatment plan and then implement it? And I would rather the dentist gets an A on the diagnosis and a C on the work than a C on the diagnosis and an A on the work. I mean, what would you, and they're so young when they come out of school, they don't know what they don't know, and diagnosing and treatment planning, I mean, I don't know how you would understand that for the first 10 years out of school.
Exactly.
What are your thoughts on how they could accelerate diagnosing and treatment planning?
I think if they're working with an elder or a senior dentist, that would be a start. I did review my cases with my mentors a lot when I was first starting out. I never wanted to practice alone. I actually like being around people. I like to talk and to have affirmation that what I'm doing is correct. And when I don't know something, it would be nice to be able to have somebody there to run a case by. So when I first started, I always had other dentists around me who were more senior and more experienced. And if I didn't have somebody that I knew was able to counsel me or guide me, I sought that out. So whether you go and join a study club, a local study club, or whether you go down the street to the specialist in your area and make an introduction, I think the specialists, when you pick up the phone or you reach out to them by whatever means, most people are very obliging because they know that if the case is too difficult, you will give them and refer them the work. So they will get business in a roundabout way. But even if they don't make any money from helping you, which most people are not focused on that, to tell you the truth, I think most of us who've been in practice long enough do want to help the younger people coming up below us. And I think most people find it refreshing, and most of us are not that busy that we can't give somebody a few hours of our time. And it's not that often. And if you get a relationship with those people, it actually is quite enjoyable to help young people because it makes you think. So I always knew that when I was coming up, you learn one, what do? You watch one, teach one, do one. You watch one, do one, teach one. So when you teach somebody, it makes you go back and think, how can I transfer my knowledge? Does it make sense? And why do I do what I do? It makes you think about what you do. And it actually helps you cement and clarify your methodology or your rationale, your philosophy. So I think it keeps us on our toes. when we actually mentor somebody, and makes you really stop to think, why do you do what you do, and what is the rationale, and makes you keep up with the literature as best as you can, and makes you want to participate. And sometimes when I go to a meeting, even if you don't hear or learn anything too different, it's reassuring to actually see that what you do is actually the current standard of care, or the state of technology and knowledge, that it's reaffirming.
So that was just amazing. You said, see one, do one, teach one.
Yeah.
And so basically what you're saying is that when you're mentoring a young kid going over a CBCT and models and a treatment plan, that you're actually benefiting from that too.
Yes, because I think it makes you organize your thoughts. It organizes your protocol, your methodology, your philosophy, so that you can express it and verbalize it and, explain it. So if you don't know what you're doing, it's hard to come across and explain it and make it sound like it makes any sense. So it helps you organize your rationale and methodology.
Okay, well, I'm gonna play the spoiled, entitled brat syndrome children that I'm having to go over now with 7 grandchildren. My 4 boys have turned into 7 grandchildren, but it's always the oldest one. He's already saying, but I'm never going to need to learn. I never need to know algebra. I'm never going to need to know that. So right now she's saying, I don't want to do dentures. I don't need to learn dentures. I'm not going to do dentures. And you're like, okay, you're not going to do them, but you need the knowledge. And she's saying, no, I'm never going to do this. What would you say to her?
For the people who say, I don't need to know dentures, they're relying on a technician. You give them a model without any teeth or very few teeth, or a deranged malocclusion that you need to restore. And you're asking that technician, set the teeth, do the wax up for me, and then give it to me all done. But that is not, as the dentist, you should be telling the technician, this is the occlusal plane, this is a midline, this is a distal of the canines, this is a smile line, this is the occlusal vertical dimension, this is the mold and the shape of the teeth that I want, this is the shade, now set the teeth for me. You shouldn't have the technician find the landmarks, the midline, the occlusal plane, the retromolar pad, the vertical dimension. How does the technician know without having met the patient? They're also not a dentist. They don't know anything about occlusal vertical dimension of occlusion, freeway space, neutral zone, lip support. How is a technician supposed to tell you where the teeth should go? Because when you know where the teeth will go, then you know where the implant should go. You don't put the implants in the bone and then just hope that the teeth can go over it. Mechanically, aesthetically, the exit points for the actual loading for the implants, nothing's going to be correct. You need to know where the teeth, where the smile line, where the phonetics, where the occlusal dimension of occlusion. Those are the basic fundamental guidelines for setting the teeth. The teeth have to be set first before you can do your implants. So that's what I would say. If you're relying on your technician to set the teeth, that is not why you went to dental school. The technician is not the quarterback. The technician should be part of your team that is told, or you collaborate and say, these are the guidelines. Some technicians have a true talent for shaping and setting teeth, and obviously for ceramics. I'm not the expert on that. But I need to tell the technician, where to set the teeth, where the incisal edge should go, where the smile line is. That is not the role of a technician.
Right.
That's what I would say to somebody who says, I don't need to know dentures.
Yeah. So when you, I want to focus on the kids in school, because I feel like you and I got out at a great time. We benefited immensely from this profession. And, they came out of school in 2020, $400,000 in student loans. To put it in perspective, Dentaltown has had free classified ads since like 1999. And there's always been about 1,000 practices for sale and about 5,000 associate jobs needed. Now it's 2,000 for sale and just 1,000 jobs. A lot of the dentists, if they haven't been divorced, if they've never divorced, They can cash out and retire at 60, no problem at age 60. If you get divorced once, you push that back a decade, and if you get divorced twice, you die at the chair, okay? So a lot of the dentists, when they start hearing all this PPE and all this stuff, they just said, I'm done selling it. What would you say to the class of 2020 where they're texting me and emailing me, say, right here in Arizona, saying, dude, I can't find a job. I got $400,000 student loans. But here's the thing about the entitlement. Here's what really is just they say, oh, well, I said, really, you can't find any job? And they go, oh, yeah, if you want to go to some DSO Medicaid clinic in South Phoenix, and there's this other one where he's on all the PPOs. And I'm like, okay, and this one's only going to pay 20%. I'm like, so you'd rather be home unemployed than working at 20% of collection at a Medicaid clinic? Because, I mean, that's just finance. You're still getting to practice people skills and trying to get a kid numb and do your art, do your craft. Yeah. What advice would you give these kids during the pandemic?
I think I agree with you that there's always a need, whether it's in a clinic that may be not the type of business structure that you're obviously ideally interested in. You've got to start somewhere. So whether you get a few part-time positions, you, as you say, you get real-world experience, you get your speed up, you get clinical experience, you get business experience, you get people management skills. So just start doing something. It's not your forever job. My first job, and I'm sure everybody's first job, was not your last job. So you learn from every life experience that you have. You chalk it up to experience, good or bad. And when you do have a bad experience, you know the next job you take, you don't want that in your job description, or you don't want to work with people or a business structure like that. So you get to kind of develop your philosophy of how you want to practice, what sort of person you want to be, what sort of manager you want to be, what sort of clinician you want to be, and what sort of dentistry you want to do. And so I think the more you see, the more you do, the more you know what you want to do next.
Specifically, so I've been telling them, you know, if you can't find a job, go specialize, because number one, I mean, my gosh, the average net income for dentist, for dental specialists, average, all U.S. general or dental specialists is netting showing $320,000 income, whereas a general dentist is $197,000. General dentists who own their own practice average $244,000. Dentists who are employees at $147,000. When you look at oral surgeons, $448,000, periodontist $330,000, endodontist $307,000, pediatric $304,000, ortho $289,000, prosto only $219,000, but it's still extremely high. Would you recommend prosthodontic as a specialty? Do you think it's needed? Do you think, yes, I would endorse it, go become a prosthodontist? Or would you say no?
I do feel it's needed. I mean, in our practice, it's referral based, whether it's from other specialists or even patients refer, because many of our cases are retreatment. And so many of patients have gone to, whether it's a general dentist or a cosmetic dentist or a dentist who say they specialize in implants or reconstructions and don't know enough about what they're doing to be effective. So whether it's, a lot of the time it's occlusion, sometimes it's due to poor execution of the dentistry, whether it's preparation design, encroaching upon the zone of, attachment and subgingival margins and causing chronic perio, whether it's a fit of restorations and cutting corners and having open margins, recurrent decay, and soft tissue problems. There are a multitude of complications that can occur when you don't have the big picture. Anybody can prepare the teeth and cut them down and remove enamel. It's the application of the occlusion, it's understanding the vertical dimension, the phonetics, the setup of the case, and knowing why the case needed a reconstruction in the first place, which goes back to the treatment planning and diagnosis. It may seem easy to do a mouthful of preparations and just, have some pretty ceramics, but if the occlusion is not correct, or if you don't understand what led to the breakdown in the first place, whether it was disease process, whether it's parafunctional process, it's not going to last. So I do believe the specialty is important because we have further training in the more complex malocclusions and occlusal derangements. And so you can't get that in dental school. So there are some super generalists who go out and do continuing education, who sign up for other additional institutes, whether it's Paquette or others, who help further their education process after dental school. And they're very well qualified. But most people who come out of dental school don't have enough training and background to be able to take on the more complex cases without further education. So therefore, it isn't important as a specialty because there are other additional, didactic training that has to be performed after dental school. You just can't cram it in and know about everything sufficiently after dental school. And with implant dentistry, whether it's, CAD/CAM dentistry, it still goes back to the fundamentals, as you correctly said, Howard, of fundamental diagnosis and treatment planning, and then how you execute it, whether it's analog or digital, the diagnosis and treatment planning is still critical. And so I don't think we get that adequately in dental school.
If you come out of school and you're $400,000 in debt, and then she wants to grow up and be just like you, and she thinks to do that, I need to go she starts her own practice, and she sees I got to buy a CBCT, there's $100,000, I need some fancy Millennium laser, there's another $100,000, a chair side milling, there's another $100,000 for a CEREC machine. She can make 3 purchases and double her student loan technology. So I'm going to hold your feet to the fire and try to get out of you. What high-tech equipment does she have to buy to practice just like you?
Well, I'm a little biased. I would say the clinical microscope, because I think that automatically will elevate your standard of care, because just to practice with loops, with a headlight, just to go and start your examination and diagnosis, you can see a lot more if you're magnified greater than 2, 3, 4, 5, 6 times magnification. So in my opinion, the microscope was life-changing. You can always refer the patient out for imaging, whether it's a cone beam or a panoramic radiograph. You can always take an analog alginate or a polyvinyl siloxane model and have that scanned if you want to do some, digital mill dentistry. But if you don't see and you miss a diagnosis, if you don't know that your restoration is not fitting and there's recurrent decay or micro leakage or, inflammation, or retained cement, your dentistry is not going to be, it doesn't matter how high tech you are, your dentistry is not going to last, and it's not going to be pain-free. Even simple things like just checking occlusion, the microscope tells you a lot about wear facets, about, wear patterns, diagnosing, cracks, just seeing how the overall dentition appears magnified, diagnosing microgaps or, open margins, overhangs, open contacts. It is immeasurable how much I think the clinical microscope has elevated my standard of care. And that came from seeing Dr. Sheets and Dr. Paquette's practice. I thought my 2.5 times loops was great until I sat down at a microscope and saw how much more I could see. And it keeps my tooth preparation conservative. It elevates every aspect of my practice, from examination and diagnosis to the execution of the clinical dentistry, to the delivery, to the final check of the cement removal, adjusting the occlusion. I think that would be my advice, because all the other technologies, you can you can farm out, whether it's the lab can scan your model, you can send it to an imaging. When we started, we didn't have a panoramic radiograph facility. We had to ship it out to the imaging center down the street. So you can still do that without having to spend a bunch of money trying to have your own cone beam CTs, having your own digital, impression system. I think being able to see properly to do your dentistry, even if you're 20/20 vision, is not as accurate as a clinical microscope and a magnified vision. So that would be my advice. That changed my practice.
So a microscope is a life-changing deal. And I still think that was the neatest thing about when I got the CEREC machine and Samir Puri came out to our office and was showing it and everything. And I got to see the first time I did a prep under 40X, and I thought I should have my license taken away, and Dr. Puri agreed. I mean, imagine if Stevie Wonder had been practicing dentistry for 30 years and he just got his vision back. I mean, it's just there's no simpler way to increase your quality than with magnification, whether it be loupes, microscope. The endodontists are using it before they obturate. And it's just, but I want to take a step further. And the assistants have to have it too. I mean, your assistant, your assistant's assisting you and making provisionals, and the hygienist, and et cetera, et cetera.
And the lab already has it. Your most laboratory basic lab, they have those, countertop microscopes, but a lot of labs have other microscopes that they check things. And as you correctly stated, CAD designed dentistry relies on a scanning, and if your margins are not clear, you're not even going to be able to adequately scan it because there's so many steps and so many irregularities, but that automatically magnifies it on the computer screen for you or the technician. So if that first step is not adequate, then every step along the way is going to be a challenge. And microscopes are not expensive. You can get one probably for, a very basic one or even a used one. And even a very good new one can be $20,000. So compared to all the other technology, it's actually not that expensive. And it doesn't break. It's like a good Mercedes. You used to have to change the light bulb, but now it's LED. It could last you for your whole practice. We've got microscopes in our office that are in place for 30 years. And we've eventually switched them out because they get a lot easier to maneuver for the new mechanics. But if you have a good LED lighting source, they just keep churning on. They don't break.
So there's, you said Mercedes-Benz. The German one is Zeiss. And then the American one is Global out of St. Louis. Yes. Which one of those do you specifically have?
Well, we have Global Microscope, but we've utilized many other microscopes in our teaching courses. I think the key for anything you purchase is follow-up and service. So if you can't reach the supporting technical team or the salesperson, if you have a question or something needs to be, modified, or if you need to buy an attachment or have some assistance, it will be frustrating if you can't reach the customer service person. And in this day and age, a physical person is still important for business. So I would say whatever system you buy, all the optics are very similar. Their lighting sources is very similar. You just need a dial that changes a few steps of magnification from maybe 3 to 5 to 9 to 12 to 14. I mean, you don't have to have many steps. You could just have 3 magnification levels. Anything is better than just having one set of loupes that you have to put down and put back on. And I think in this day and age, they're all very reliable. Nothing really breaks. You need somebody to help you with installation, with attaching a video camera for documentation. It's the best teaching tool for patients. If you can show a patient what a crack looks like, if you can show a patient what a deep pocket and a bleeding, calculus, pus draining pocket looks like, the patient immediately understands what periodontal disease. If you can show a wear facet and the occlusal scheme with the balancing interference and mobility and recession and bone loss, the patient gets why their bite is so critical for their health. So I think if anything you can take from this is not only does it elevate your quality of dentistry, it helps you communicate with your patients. It helps you, if you want to put it crudely, sell your dentistry. Because once a patient sees what disease process looks like, what pus looks like, what calculus looks like, what a pocket looks like, what a crack, what a recurrent decay, what an open margin or an overhang looks like, they will understand why they need that restoration replaced. You don't have to sell them anything. They will want to change it because it looks terrible. They know the disease is present. So I always tell patients, your mouth does not have a separate entry to the rest of your body. It is a communicating railroad system. The blood vessels communicate with your mouth. So if you have a point of disease with bacteria, that can go anywhere in the whole process in your body. Most people think, the mouth is separate from the rest of the body. It is such a source of biofilm and bacteria for our overall health. It is critical to your overall health and inflammation and chronic level of disease. So if you can demonstrate to a patient what is going on in their mouth, whether it's basic hygiene, they will get it and they will want to floss. They will want to come back for that root planing and pocket reduction. They will know what is going on in their mouth. So they will want to proceed with, getting that rectified.
And when you said, you embarrassingly said to sell dentistry, and I'm one of those unapologetic, business, it's supply and demand. And if you can't sell it, you're not a good dentist. And I keep trying to tell these dentists that some of the people who think they're the best dentists in the world, they don't even realize they're not at all. Because if you tell 100 kids that they have a cavity, and you can only convince half of them to come in and trade you a coin to get it fixed, and the dentist across the street told 100 kids, and 80 got it fixed, the dentist who did 80 amalgams is better than the dentist who did 50 composites, and better than the dentist who did my 8 gold inlays and onlays. Yes. I mean, there's something about selling dentistry. And I always thought, like on your website, this is a class example. You got to check out her website. Her website is sheetsandpaquette.com. Paquette is is that French or French? Or from Paris?
Dr. Paquette is Canadian from
Montreal.
Montreal, yes.
So, but anyway, you show your own work. And my gosh, my plastic surgeon friends say that the reason they crush it is because they'll go to all the plastic surgery doctors and all they have is brochures and posters and all this. And when you go to his office, this is my work. And when you're, doing something, and I think the little digital camera, which I don't know what a digital camera costs, but it's got to be probably about the same price your iPhone, under $1,000, $500, whatever. But when they go to your website and they see your work before and after, I think that's the greatest sales deal. And then to put that in perspective, like sometimes I'll be having dinner with a friend who in town who I know really loves implants, and that's his whole passion. He just loves implants. But man, you go to his website, you'd never even know it.
Yeah.
And but if he showed me, if his website had half the before and after pictures that he's showing me at a bar on his iPhone, yes, I think he'd double his practice.
Yeah, I think in this day and age, people want the visual, and so that is a fast way to communicate what you do. And so we even have to update our website more and have more interaction and more click on hyperlinks, because the words is not where it's at. People want movement, people want visual and fast information transfer. So we need to kind of continue to evolve, and our website is a little dated, but still we are a visual profession. I think people also believe that obviously pain gets people in the door as well, but beauty is a large part of what we offer our patients as well. But we hope that what we offer is not only beautiful, but pain-free and gives people the longevity as well. So, visual is, I agree, very key. And that's why We videotape the end of our examination at every new patient or re-examination appointment, because I always say to patients, I'm going to videotape the highlights from our examination today in order for me to communicate with you what I see in your mouth and what the situation is, so you can better understand the condition of your dentition and know what your level of health is and where the issues are that we've been discussing. Because as I videotape their mouth through the clinical microscope, I am describing on purpose what I see, A, for the patient to hear, but B, for my assistant to know that what I want to capture is the distal aspect of number 2, the 6 millimeter pocket and the bleeding and the drainage. I want to capture the mesial of number 5 to show the marginal ridge fracture and the micro leakage and the crack in the tooth. I want to show them the lingual aspect of number 9, where there is some, recurrent decay around this margin of this restoration. Because if I'm not centered and I'm not capturing that distal aspect, when I come back to play it, it's either out of focus or off center, and I don't have that information. So my assistant knows I'm trying to capture a certain area, they'll say, move to the left, move up, move down, because what I see is a wider field of vision than what the microscope will capture, which is right in the center. So when I play it back, my patient says, oh, yeah, that's what you were talking about. There was decay there. Oh, you were talking about that bleeding. And they get to see and hear one more time, for a second time, what I had just described. So it's very important for them to get the verbal while I'm recording it, and then the visual as a playback.
I never got on who has better support in person on a dental microscope.
I must admit, Global does. And I don't want to talk badly about any company, but Global has a bigger support team in the United States, because Zeiss is not US based. And so they're getting better. They're hiring more people. And then now Sullivan Shine is, I think, the parent company. So I think that will further improve their ability to support the consumer.
So you're saying Stan Bergman has Shine bought Global or Zeiss?
Zeiss,
Global?
I believe.
Stan Bergman bought Zeiss? Or they're the exclusive distributor for?
I believe they are.
Yeah.
Yes.
Huh, that is amazing. Yeah, but yeah, it's the same thing. I mean, you call these companies, and there's a lot of people who, when they get an automated deal, push one for this, they just hang up. And
it's terrible. And then you're on hold forever and you never get anywhere.
Yeah, there's a lot to be said. And another question they're going to have is a lot of people who sell chairside milling are saying that there's cosmetic dentists out there, top of the line cosmetic dentists that are chairside milling their anterior veneers. Maybe I'm old, but aren't really the best looking porcelain veneers still like stacked porcelain or in a lab or whatever? Or are you? I mean, you're about as elite as they come out there in California. Do you do anterior veneers yourself, chairside milling, or do you still use a lab tech?
We still use a lab tech. If we do mill, we do in many cases have to customize, whether it's a shade or whether we cut back and do some veneering porcelain. I think in our practice, we're not the run-of-the-mill single shade veneer. It is we're known for our customization, and to do a single veneer, I think it's impossible to have a monolithic veneer that is going to match your other central. I've never seen one. So if you're doing 6 or 4 veneers, maybe you can be monolithic and just have one shade and mill it. But to mill Emax or lithium disilicate is extremely difficult. I think that the pressed lithium disilicate is far superior in terms of fit and reliability. A lot of the time when we try to mill the lithium disilicate, the burrs often break. You can definitely mill zirconia and then sinter it more reliably than milling a Emax or lithium disilicate material. But I don't do many zirconia veneers. I know it can be done, but I still think the beauty and the translucency of lithium disilicate or Emax is far superior. And then when we have a really challenging case, as I mentioned, we cut it back and we veneer with a overlaying feldspathic porcelain. And in some very challenging cases, we'll still go back and do feldspathic, only if you have underlying enamel to bond to for optimal strength. If you're just on dentin, it's going to be challenging to use feldspathic and have the reliability and the strength.
And are you scanning more of your impressions digitally, electronically, or are you still old school vinyl polysiloxane?
If the case is super gingival, and the scanner will be quite reliable, and so we will scan if it's a limited, segment. If it's a full arch case, we're still old school for sure, polyvinyl siloxane. It is extremely difficult right now to have a full arch accuracy for just a digital impression. If it's a subgingival margin, it can be challenging unless you use electrosurge or a laser to really expose your margin in order for the scanner to read it, even if you zoom in. So in my opinion, if it's a equigingival or a supergingival finish line, you can scan all day. And as long as it's a limited segment and not a full arch. If it is subgingival, difficult to see margin, or a more comprehensive cross-arch case, then I would do polyvinyl siloxane.
Okay. When people say that prosthodontists are so expensive and it costs an arm and a leg, don't you say, no, it costs a tooth? I mean, we're prosthodontists.
I had one patient, Howard, a very intelligent businesswoman who had shopped around. She was losing her dentition due to her past history of perio. She went to Clear Choice. She went to several cosmetic dentists, and then she came to our office. And what she said to me was, she saw our facility, she interviewed us, and she said, in my opinion, I want to pay it once, do it right, and do it once. So when she went to interview other offices, for whatever reason, she felt that they were not either good communicators, or their facility didn't give her the confidence that they were able to do the job. She had been to a cosmetic dentist for many years, and she made the decision to leave because she knew that her dentition was falling apart, that they were doing piecemeal. If one tooth broke down, they would fix that one tooth. Then another area broke down, they would fix the other area. And then her occlusion was not stable. The colors didn't match. The embrasures were packing food. She knew that there wasn't a comprehensive approach. And so when she interviewed us, she met our technical team. She knew that there was support. She knew that what we offered was a more methodical approach. And she knew that Clear Choice was not for her because she felt like they were too much into selling her that they could fix it quickly and they could offer her a solution that was immediate, but she didn't feel confident that it would last. And so every day every time I see her, she always says to me, I know you're expensive, and I know what I have in my mouth is not for everybody. Not everybody can afford this, but I am so grateful that I've proceeded with your office, in that I know that I do it once, I do it well, and I don't have to touch it again. And so I think that's when people say you're expensive, I always tell them we want to do it right. We take the time to get it right, and we will stand behind, obviously, our work, that it should last you, I never say a lifetime, but it should last you a long time. And whether it's biological health, whether it's aesthetics, whether it's functional comfort, it has to be all of the above.
So I want to teach the kids a term about channel conflict. Now, I'm pretty sure about a quarter of our listeners are still in dental kindergarten school. The rest are under 30. And by the way, please send me an email, howard@dentaltown.com, or leave a message in the comments under YouTube. I love getting that feedback. But a lot of times they don't understand, like they're thinking, if I'm a prosthodontist, well, I may want to surgically place the implant and restore it. But then they learn in the real world that when they start placing an implant, now that oral surgeon or periodontist who used to place them and had you restore them, they lose that revenue stream. And then they have to decide, Well, will the revenue of placing implants, will that counteract the revenue lost? And then there's just the specialty. Some think there's so much time and knowledge needed to surgically place it and a totally different set of restoring it. So my question is, you have a 3-person team.
Yeah.
Do you place them and restore them, or do you only restore them, and why?
We used to only restore them, and Dr. Sheets is still the restorative part. She's not interested in the surgical part. Dr. Paquette and I, and also David Gachet, who is one of our associates as well in our office, we're interested in the surgical aspect, and we've further trained in the surgical aspect. I think there are some cases where there are no compromises with the hard tissue and the soft tissue anatomy, where there could be an ability for the prosthodontist, if they're trained to do the surgery, to do the surgical and restorative part of the rehabilitation. And in most prosthodontic training programs, they are teaching the students or the residents how to place the implants. But in other more complex situations where there's a bony defect, whether there's complications with the soft tissue, and maybe whether it's in the high lip line kind of aesthetic zone, we understand our limitations and we will definitely refer to a specialist. So it's just like Invisalign or minor orthodontic treatment. We do Invisalign and clear correct and other aligner therapy too before we reconstruct the case, because we understand there are in certain situations where the skeletal structure is a class 1 malocclusion. We feel confident that we can set up the case using minor aligner therapy before we do the veneers, before we do the tooth preparation, because it will be more healthy for the patient. But there are other situations where we'll refer to the orthodontist because it's out of our realm of training. So I think it's case selection, it's further training, and it's also whether you're interested in surgery. There are people who find that that is an interesting aspect of what we do and want to pursue it and then go and have further training. But we need to understand our limitations and select the cases appropriately. And we still need our other co-therapists, because there are many situations that are you need to understand is out of your area of expertise, and you need to refer.
Now, your father-in-law is a very famous prosthodontist, correct? Niles?
Justine Paquette's husband, father-in-law is Niles Gachet. Yes.
Oh, okay. My gosh.
David Gachet. David Gachet's father is Niles Gachet.
Oh, okay, I messed it up. But who was the, okay, so Dr. Paquette married Dr. Niles Gachet's son.
David.
All right. But who was you said you have another dentist working for you. What was his name? What was the last one?
David comes to us a few times a month to treat our TMD patients. David Gachet.
Oh, him.
Yes, him.
Oh my gosh, I did not know that.
And he does quite a lot of surgery. He loves to do surgery, and he does a lot of full mouth reconstructions with
David Gachet does.
Yeah.
Okay, I did not. So, so Niles Gachet's son, David, is also, they're both prosthodontist?
Yes, and also his brother, Greg Gachet, is a prosthodontist. So Greg and David work together in the city of Orange. Niles is now retired, their father, but they used to, all three of them practice together.
So that was an amazing answer. To implant surgery, here's another thing. You know, I love cynics. I love it when you tell them about a rose garden and they say, that ain't roses, those are dandelions. In this country, it seems like all the implant training is sponsored by a manufacturer. So then the kids ask, I think very logically, do you have to pick your implant system because that's where you're going to get all the training? Do you pick the implant first and then go get the system? Or how do you get training on implants? How would, she's saying, I want to be like you. I want to get more training. Where can I get more training? I mean, obviously, if I go to Nike, they're not going to tell me the advantages of Reebok or Puma. So right. How do you get training that's not manufactured by us? In fact, I think the ADA is going to come out with something very, very controversial, and a lot of people are for it, that the continuing education hours doesn't count from manufactured sponsored courses. It's got to be accredited through an institution, not a sales rep.
I think ADA SERP guidelines are very strict, whether it's from the advertising, whether it's sponsorship. The Pacific Coast Society for Prosthodontics, I'm on the executive council. We have very strict guidelines from ADA on how we advertise, how we devise our courses, how we're sponsored, how we have the disclosures. It's very strict. So I think that is very good for the profession to separate the sponsorship. I know we rely on sponsorship for many of our physical meetings, and because of COVID, we haven't had one for a while. But when we do resume these physical meetings, the sponsors have an important role to help us hold these courses. But we need to understand that the education component has to be independent. And so what I would tell people, if they want to learn how to do more dentistry, we started mentoring with an older oral surgeon who we used to refer to. We would sit down and treatment plan. We would review the cases together. In the beginning, it was because we were treatment planning together. As we learned more from him, he would say, well, why don't I come and do the case in your office? You can look over my shoulder. And then the next case was, well, why don't you do it and I'll look over your shoulder and watch you do it? And he would just guide us. And then there were situations where he'd say, this is too difficult. I'm going to do it. You watch. And in the future, you may never do a sinus lift. And I never do, but Justine and others, there are certain cases where they can do their own complex surgery because they've continued to develop their craft. But we mentored with an oral surgeon, and then we also went to continuing education courses independent of a company. And the companies, don't get me wrong, do have a role to play in understanding their system, but the rationale and the fundamentals have to be in place first in order for you to discern whether that company has a design and the type of prosthetic components that you're interested in. You shouldn't be told by the representative what is good about the implants. You should be able to seek them out and say, well, I like your implant because of this design. I like your implant because of this this component or this type of support, or this surface design, or this Morse taper, or this thread system. So you should be able to understand what they're telling you and what the literature says about the microgap and bacteria and the mechanics of their connector. So in order to be able to be a discerning clinician, you have to get the fundamentals first, and that has to be independent. And there are many ways you can do that. You don't have to have a full-time, postgraduate degree. You can do a residency, for a few weekends, or whether it's a week or 2 weeks, and then build upon that step by step. But I think it's important to start with a mentor first.
I cannot believe we already went over an hour. My God, I feel like I'm cheated. I've been looking forward to this all weekend, and my time's already up. Can I keep you for a little overtime? Or I know you're in the middle of the fire.
Yeah.
And then the other advantage now is we're over an hour, so if I get too controversial, we can just cut it off. No big deal. But all on four. A lot of young kids ask very, obvious questions. That, is an all on four, you lose one implant, is it an all on none? Would it have been better maybe all on six? And then the other thing they ask about is the fact that how do you draw the emotional line where if you could snap it out, that grandma can put it under the sink and brush it with her hands and she can get it all clean. But if you make it fixed where that can't happen, every time she comes in, she has a complete ham sandwich underneath her all on four. Yeah. So what do you think of all on four versus all on 5 or 6 or 7 or 8? And how do you draw the mental health of saying, I don't want it to be able to come out of my teeth, versus the dental knowledge is, well, the reason you lost all your teeth is you don't really brush and floss and all that. So I know I threw a lot out there at you. How do you want to approach that?
Well, I think that what the patient wants is a huge driving factor. There are patients who don't care that is going to be a challenge. If they can come in frequently for us to maintain the case, and if they do some basic things such as water picking, whether it's putting any biologics, whether it's a Clorox bleach solution in the water pick, whether they will use some sort of, other device, whether it's a, basic electric toothbrush or supplemented with water picking. There are some patients that come to us once a month for maintenance because we know they're not physically able to maintain their plaque control. There are other patients that come once every 2 months because they're a little bit better. So I think the maintenance program is key for those patients who insist on something non-removable. For other patients, that probably is their best option, is to have a removable, overdenture retained by a few implants, whether it's because of hygiene. Sometimes it's financial. It's much cheaper to do an overdenture than do a porcelain fully fixed case on multiple implants. I think all on four, if it's well designed and it is well maintained and mechanically engineered appropriately, obviously can work. But it is a little risky in certain situations where if you do lose one, what do you do then? Do you have somewhere where you can place a replacement, and then the cost of that? So we do more all on six because we know the spread of the occlusal load is more distributed. But there are some situations where maybe you can't do six. Maybe there's not enough bone distal to the canines and you have to do just four. So I think it goes back to treatment planning. It goes back to the biological health of the type of bone and the level of maintenance that you can foresee after the reconstruction, because that is going to be critical for the long term or the longevity and the maintenance ability. Sometimes it is the patient dictates. Most patients don't want something removable. How can you design something that can be maintained and is structurally sound in good, healthy bone and mechanically well designed so you don't have a huge cantilever? I think there are a multitude of factors. So you have to give patients what they want, or they'll go elsewhere and get it somewhere else and have maybe an inferior, design, or what it won't last is not as good quality as what you can offer. So I think we need to create a balance between giving the patient what they want, but knowing that they're not the educated person in the room. They just know that what they want is something that is as natural as possible. How can you get them to that point in a safe manner? It's your responsibility as a clinician to be able to advise the patient. And if it's really not a good idea, whether it's because of bone structure, whether it's due to anatomical restrictions, whether it's because there's such a poor hygiene risk, then patients will probably accept, if you can present the case in a manner that is understandable, why it is not responsible to give them a fixed case. And they will accept if you can get something stable enough that it is going to be the best for them and be the best way that they can utilize their funds and have something that will last and be healthy.
And how much of what you do is cosmetic versus form, fit, and function?
I think you can't separate the cosmetics. If you want a patient to be satisfied when they pick up the hair mirror at the end of a delivery, it has to all come together. It can't be well-functioning and strong and be ugly. In this day and age, nobody wants something that's not attractive. So I think it's our responsibility as the trained specialist to give them the form and function that they don't understand. They don't know what centriculation is. They don't know what vertical dimension means. They just know that it looks better when they're not collapsed. They just know that their bite feels better when they have a stable occlusal scheme and that's mutually protected and that nothing breaks and they don't have any interferences. They just know that it has to be comfortable. It doesn't. They don't want things breaking and chipping and falling off or coming loose, and they just want it to look decent. So I don't think you can separate how much of an importance. I would say that it has to be an even split. If something looks great but doesn't work and it breaks, you failed. So I don't see that one is more important than the other. The aesthetics, the stability, the biological health, the form and function, it's like a Venn diagram. It all has to intersect.
Very, very, very well put. So then I almost didn't want to ask you this because it's just so many cans of worms, but why is occlusion so mystical? Why do they come out of school and they know Streptococcus mutans causes decay and P. gingivalis, but man, when it comes into occlusion, they come out of school and it's like this mystery wrapped in enigma.
I don't know, Howard. I guess it falls back to the teaching. I think once I had it explained by, Dr. Okerson, there's a book, I think it's called Occlusion. When I saw the diagram of what it means for centric elation to have the condyle seated in its most retromolar superior position, I just think of it as home base. I explain it to patients. I can try to take your bite just with you biting together, but if you have an interference or if you have a tooth that is out of place, you'll slide to get your teeth into fitting into a good fit. But that doesn't mean that your jaw is in a home base beginning position. I think of centric elation as the beginning position, like home base. From there, we can move to excursive movements, to chewing motion, to speaking, but you've got to have a reliable home base to be reliable to come home to. So I give the analogy: if somebody came in with no teeth, how can you get them to bite together? You can't just gum it. You have to have a stable physical position to put the mandible in. And so then you use your wax rims to find that home base, which is centric elation. It's not centric occlusion because they have no teeth. So when they do have teeth doesn't mean that it's in the right place. It could have a crown that is in an interference, or they could have a malocclusion. It doesn't mean that the condyle is in the right place. So I think if you had a visual, like Bite FX is a really helpful program to teach people what occlusal slide, what occlusal imbalance, what an interference looks like, what a cusp fracture could mean if you have a balance interference. I think if kids had a interactive 3D model that was visual and they could spin the mandible around, they could look at what the condyle does when you have a mutually protected occlusion, when you have guidance, when you don't have guidance and you have balance interferences, then they'll probably see a slide. They'll be able to understand what a Bennett's movement is. They'll be able to understand why you set the condyle with a condylar inclination. And then you can see how the cusp angles fit in with the condylar inclination. That's when I actually got it, because I'm very, very visual as well. And when you physically have a skull and you can move the mandible on a skull and you can see how it translates down the articular eminence, then you actually understand why you have to have centric elation, because it's a repeatable position with no interferences from teeth, because teeth are not always in the right place. And if you just restore to fit in with the occlusion that somebody walks in through the door, that could be an incorrect setup, and you're just perpetuating an incorrect bite.
I remember when we got out of school, the scariest thing in the world was that you were going to open someone's bite. I mean, they were just like, it seemed like we were always thinking with our brakes on, because if we did that, you knew their arms and legs would fall off the next morning. What would you say to someone who's very, very afraid that they might be opening the bite?
I think when you open somebody's bite, it doesn't really matter how much you open them, because most patients can accept within limits. If you opened up 2 millimeters, 3 millimeters, 4 millimeters, however much you needed to open them to create restorative space, to level their occlusal plane if it's uneven, as long as it's even and balanced, and it's you have some sort of guidance and it's protected, it'll work. Many times we'll test it, whether it's with a occlusal splint before we actually start the reconstruction, in order to get their muscles and their TMJ comfortable, in order to find the centric relation, because many times the muscles are in spasm, they're in pain, they're bracing, they're uneven. Many times an occlusal splint will help you test the occlusal vertical dimension of occlusion, but we also test it when they're in provisionals. And many times patients will come back and say, oh, that actually feels quite comfortable. I actually like it. Because when somebody is overclosed, it actually puts a lot of strain on the muscles and the ligaments. And it also looks very aging. And most patients like to look more youthful. So when their occlusal dimension is open, it actually supports and keeps the condyle from overclosing and impacting the soft tissue. But it also looks good, not only feels better, but as long as their bite is even bilaterally and they don't have any interferences and they have some sort of guidance, most patients will accept what you do. We've opened up to 8 millimeters occlusion. That would be very concerning initially to a young dentist, because you think, wow, that is so much. How can they tolerate that? How can they accept that? But the neuromuscular adaptation is actually quite receptive as long as everything is balanced. If you just have them hitting on one side, whether you open them up 1 millimeter or 8 millimeters, they're going to be in pain. If they're hitting evenly bilaterally, that is heavier in the posteriors, lighter anteriorly, and you have some sort of anterior guidance so that you're not overloading the posterior teeth during function, they're actually going to be quite pain-free and comfortable.
I just want to remind the kids in school that when I was in dental school, they were telling us that the denture was just at the brink of extinction, and that they would just, they're just going down and almost never down. And to be honest, 32 years later, the United States does more dentures in 2020 than they did in 1987. Did that surprise you? And the other thing is, everybody wants to be, when you go to a CDA meeting, everybody wants to go to the sexy speaker talking about all on four. No one's going to go to some ugly guy doing all on none. I mean, if you want to be sexy Superman, do all on four. But man, God, it's like the all on none is this embarrassing thing we keep in the closet and all that kind of stuff like that. What do you think about dentures? Are they dying and going away, or do you think they're going to be here till your grandchildren have children?
I think they're always going to be there, Howard, because not everybody can afford an all-on-4, but even not talking the economics of, because you shouldn't diagnose with somebody's pocketbook. Anybody who comes through the door, if you don't know how to set up teeth on a denture, I don't think you can do all-on-4. As we go back to what we were saying before, are you going to have the technician tell you where the teeth should go, and you just place the implants and tell the technician to design the case? I don't see that is our professional responsibility. It is our responsibility to diagnose and set the teeth first in order to know where the 4 should go. I mean, obviously there has to be bone and there has to be some sort of fundamental, foundation for the implants to be integrated. But how do you know how to put the teeth on the 4 implants that you've placed? That has to come before you actually place the implants. So whether it comes with a surgical guide, the surgical guide has teeth on it. The surgical guide has to be made on some sort of diagnostic setup before you can actually do the surgery. So if you don't know how to set teeth and do the diagnostic wax up in order to do, whether it's even digital on the computer, if you don't have any fundamentals and you just have a technician set the teeth on the computer, I don't know how that can be acceptable. You're a dentist. You should know how to set the teeth. You should be able to work with the technician and be able to review what the setup is and say, okay, this is not correct. This occlusal scheme is not going to work. This is off the ridge. This is not the correct occlusal dimension. You've got to test it. You can't design a surgical case and not have a try-in, or at least know that the denture that they walk in with is acceptable, or if it's not acceptable, you need to modify it or remake it. It's very, rare that somebody comes in with a perfect dentition and then you just follow that and convert it to an all-on-full case. Many times you have to change their occlusal scheme or modify or improve upon what they come in with before you can deliver or have a surgical plan and deliver a case.
The American College of Prosthodontics has a advertising campaign, and they're trying to build the brand. It's called Go To. I mean, their website is Go To a Pro. And I love it because pro, that's kind of a pun. Go to a prosthodontist. Go to a pro. Florida was big on Florida orange juice. Do you think that Go to a Pro, with 331 million Americans, do you think they have established a brand where a lot of people know the difference of a prosthodontist versus a general dentist? Or do you think it needs a lot more money and a lot more work?
It needs a lot more money and needs a lot more work. I think everybody knows what an orthodontist is. Everybody knows what an oral surgeon. A lot of people know what a endodontist is, but very few people know what a prosthodontist is. They don't even know how to spell it. I think it is probably always going to be a struggle because most people will say, well, why can't my cosmetic dentist, why can't my general dentist do it? And there are some general dentists and cosmetic dentists who do an excellent job, just as well as a prosthodontist. But then there are other cases where it is more complex, and there are other people who may not have had enough training, even as a general dentist, in order to do it. So I think to go to a pro is just like if you had open heart surgery, you don't go to the internist, you go to a cardiologist. I had a patient actually tell me, we did a marketing campaign for the American College of Prosthodontics, and she said, if I needed heart surgery, I don't go to a general dentist. I don't go to my family doctor. I go to a cardiologist. I go to the heart doctor. If I need a complex full mouth reconstruction, I will go to a specialist who does that. I know the general dentist may not have the training in order to do that. Now, there are obviously some very well trained dentists who can do everything. But I know, for one, I can't do endo. I can't do wisdom teeth. I can't do complex periodontal plastic surgery and reconstruction, rebuild a papilla or root coverage or free gingival graft. I know I would go to a specialist. So if I had cataract surgery, I don't go to a foot doctor. I go to an eye doctor. So in order to go to the pro, if you have a very simple crown, you can go to a general dentist. If you have a very difficult, hard to match central veneer, I might want to go to a pro because it's going to show if it's not right. Or if I have a full mouth reconstruction with many problems, I think it's too complex for a general dentist. So there are specialties in medicine for that very reason. In order to avoid complications, in order to know that the person who's doing your case has had more experience, more training, more knowledge, in order to encounter or actually avoid problems. If you encounter a problem, that's a little late. You need to plan the case so that you don't get into trouble.
Very, very nice. My gosh. So the last question, I'll let you go. I know you're on fire out there. You're calling from a hotel. I'm so honored to have you come on the show. But I see something very bizarre where you look at the trend. 1900, no specialties. Healthcare is only 1% of the GDP. By the end of the century, it's the physicians have 58 specialties. The dentists have 9. It's now 14% of the GDP. You go out to 2020, dentistry's up to 12. It's now 17% of the GDP. And yet these kids come out and they're not gonna specialize. They're gonna do endo and perio and pedo and implants and veneers and cosmetics, and they just want to be everything. And although I applaud their youth and enthusiasm, and I think it's so exciting and fun, I mean, we're not going back to the 1900 where one doctor does your eye, ear, nose, throat, and delivers your baby and amputates your foot. How do you train the mind of the young kids that says, okay, if you're going to add implants to your curriculum. I mean, are you going to add bone grafting, and you also said in the same sentence that you want to go into Invisalign and align technology, and then you want to learn silver diamine fluoride for pedo, and you don't do, how can she be at 25 when she walks out of school? Can she be Wonder Woman and do it all?
I think you probably have to take it in a stepwise manner. Do the basics well, examine the patient well, communicate with the patient, maybe do some basic perio well, do some single restorations well, and then add to that module and say, well, maybe I'll do, a quadrant next time. I'll be able to do multiple because I understand maybe the occlusion better. If you're doing a single tooth, it's probably the occlusal scheme is set up for you. You're not going to change the occlusion. You're not going to change the occlusal vertical dimension. So I think if you do a limited case well, then you can add to that. And always, we're still undergoing continuing education. We never will stop until the day I retire, because there's always something that I can do better. There's always something that I need to understand more, or something that needs to be refreshed, or just to collaborate and say, oh, there's another way of doing this. I can hear from somebody else. Maybe there's improvements in materials or methodology. I think you shouldn't feel in your first few years of practice that you will do anything well. Even if it's just a class 1 restoration, it takes time to do that well. Whether it's your anatomy, whether it's your, caries detection, whether it's your dexterity, whether it's your handling of a material. I think whether it's your adjustment of the occlusion at the end of the restoration, I think you need to understand that you can keep building on your ability. And there are some things that you do well and some things that you don't do well, and that you will understand you need to refer, or some things that you don't like to do. I think in order to be one person for everything is extremely challenging. And I think that is dangerous, to think that you know it all. And most people come out of dental school thinking they know enough. And that is so far from reality. As soon as you enter practice, if you are humble and if you have a questioning mind, you will very quickly realize you know nothing. And you need to talk and learn and watch and continue to learn. And there's so many ways we can learn now, whether it's YouTube, whether it's on, Dental Town, whether it's on any, just Google a procedure. There are many ways that you can educate yourself. And then there are more structured courses that you can participate in. So I think you need to always be questioning, how can I do that better? How can I learn more? And how can I keep building on my knowledge base, because it never stops.
It was such an honor to podcast you. I mean, I contacted you guys the first, when we started doing it 4 years ago. And I'm glad you waited, because now the audience is so much bigger for what you deserve. I just think you've opened up so many doors for so many people. You're on every committee. I mean, you guys, all three of you are legends. And to think that you're in one building is just crazy. Was there anything you wanted to talk about today that I didn't bring up?
No, I think dentistry is not a dead profession. I think what I am surprised about is how exciting dentistry can be. There are many challenges, whether it's COVID, whether it's the economics of maintaining, an economically viable business. But I think you should never forget that if you're honest and you give your best every day, and that you treat patients and people that you work with well, and that you have integrity, that you strive to be the best that you can be, you will do well. Don't be scared and depressed by the world affairs, by COVID, by having to wear 2 masks and a shield and a gown. We can overcome all those obstacles as long as you know that you're providing a valuable service to your patients. And if you do a job well, you will make money. you will make a good living, but you need to do your best, continue to strive for excellence, and the people will come because you are providing a good quality service. And till the end of time, people will need dentists. And so you will be a survivor if you provide quality and have integrity and honesty. So don't take any shortcuts and lose sight of that.
So basically what I heard you say is if integrity and sincerity and honesty is so important that once you can fake that, you got it made.
Yes, and be able to communicate that and
Go
be
get
believable.
it. Once you can fake that. That was another attempt at a joke. Hey, thank you so much for coming on the show. I'm so sorry. Are you in harm's way, or are you?
I've got my phone is. I've got 18 messages. People are asking me how we are. I don't know. I'll have to check the news and see what's going on out there. I think the fire is still not contained, but I'll have to see how close it is to the homes.
Well, if you run out of beer, I can get to the ocean in LA in 6.5 hours. So remember, the most you'll have to go without beer is 6.5 hours. Thank you so much for coming on the show today. It was just an honor and a privilege to be able to podcast you.
My pleasure.
All right. Have a great day. Good luck on that fire.
Thank you, Howard. Bye-bye.